Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. Today, I have the great pleasure of inviting back on the podcast Dr. Mary Lateo from Memorial Sloan Kettering Cancer Center in New York City, and one of the fellows, soon to be a senior fellow at Memorial Sloan Kettering Cancer Center. Also, her name is Sarah Andres, and also the author of the July lead article for the International Journal of Gynecological Cancer. We're really excited to speak about this article, of course, a very pertinent topic. The article is titled Successful Bilateral Sentinel Lymph Node Mapping Rate and Empty Nodal Packet Rate in Uterine Cancer. Sarah, Mario, welcome to the podcast, and thank you so much for accepting our invitation.
Thank you.
Thrilled to be here.
Excellent. So we have, as usual, a number of questions, and many of them are from our fellows in the journal. So I wanted to start with you, Sarah, and just for our general clinical audience, can you break down the definitions of a successful bilateral sentinel lymph node mapping versus an empty nodal packet, and what are the implications of the two and the nuances between the two?
So successful SLN mapping requires following the SLN algorithm, which means examining the nodal basin for suspicious or grossly enlarged lymph nodes, mapping bilateral pelvises, identifying the sentinel lymph node, and resecting it with then subsequent pathologic examination, verifying the presence of nodal tissue in bilateral SLN packets. You must identify the sentinel lymph node. So that's the first node in the nodal basin that receives lymph flow from that tumor. And an empty nodal packet is different, and that's when there is no microscopic evidence of nodal tissue within the surgeon-designated sentinel lymph node packet.
Excellent. So great start, and I'll move over to Mario. Um, Tell us why is evaluating sentinel lymph node mapping rate specifically with ICG so critical now? And also, in other words, what gap does this study fill that was not already known?
Yeah, so as you know, we've published a lot on sentinel node mapping here for your uterine and cervix cancer, but we actually started doing this in 2003. And so and then ICG became quote unquote the standard based on the film study, which was a randomized trial that was done between our site and MD Anderson with our great friend who passed, Michael Fromovitz. And that showed that the detection rate was significantly higher with ICG. So we wanted to, and we have published on our detection rates, and we had kind of noticed that we were just getting better. So we want to see a large series and update and sort of validate that the film study in a real world sense. Patients who go on randomized trials, often their characters are slightly different. And also, we had seen lots of studies looking at detection rates in smaller series, and then BMI was always a concern about successful mapping. So we just want to see what our updated rate of successful mapping was after nearly 20 years of doing it, and then across different BMIs. And also, again, see if the results from the film study were really holding up, or could we even gotten better since the film study?
Yeah, that's great. And as you say this, for 20 years is amazing. Of course, obviously how time passes because
Yeah.
I do remember some of those early years when your institution was starting to do this as well. So, oh boy, it gets
Yep.
it times us. So, Sarah, I'll turn to you and talk a little bit about the methodology of the study. What was the inclusion criteria in your primary objective?
Yeah, so this project included all patients with newly diagnosed clinically early stage uterine carcinoma who underwent hysterectomy with sentinel lymph node mapping with ICG from January 1st of 2014 to December 31st of 2022, so an 8-year period. Our primary objective was to report successful bilateral sentinel lymph node mapping rate, and our secondary objectives were to assess the empty nodal packet rate and then factors impacting our successful SLN mapping and empty nodal packet rates.
Excellent. Let's get to the results. Can you walk us through the baseline characteristics of the patients that were included, median age, and the breakdown of histologic subtypes? And then, of course, obviously, what did the study find?
Sure. We included 2,690 patients. Their median age was 63 and ranged from 25 to 96. The median BMI was 30.9 and ranged from 14 to 70.2. 93% of our cases were completed with minimally invasive surgery. Regarding histology, 70.4% were low-grade endometrioid, 9.7% were high-grade endometrioid, 8.6 were serous, 4.4 carcinosarcoma, 3.6 mixed, 1.6 clear cell, 1.1% undifferentiated, and then less than 0.5% were sarcoma, mucinous, and mesonephric-like. The successful bilateral SLN mapping rate was 87% across the whole study population, and the empty nodal packet rate was 3.7%. We found that increasing age and BMI were associated with worse sentinel lymph node mapping success. The surgical approach via laparotomy was also associated with worse SLN mapping success at 75% for cases completed via laparotomy versus 88% for cases completed in a minimally invasive fashion. And we additionally found the SLN success rate increased over time. So in 2014, our overall success rate was 82.5%, and then in 2022, it was up to 91.3%.
Yeah, she
Excellent.
also wanted to sort of try to help
Yeah.
establish sort of some goals for, successful bilateral mapping. There's a lot of publications out there that report lower rates and then try to come up with all the reasons why things don't map. But I think that with the gaining experience over time, you can get a very high successful bilateral mapping rate. And also, which we don't mention here, is that there were differences between individual surgeons here also.
Mm.
Um, a little more of a sensitive topic, which we didn't put in the paper, of course, but even among the surgeons here, there was a variation in successful bilateral mapping rates. So, this is as an aggregate of about 15 different surgeons, and still we were able to get overall pretty high rates.
Excellent. And we'll get a little bit into the techniques a little bit later. Mario, I'll start from our fellows, questions from our fellows. This next question is from Eleonora Panizzolo from the University of Padua in Italy. And she's asking, this study, as you mentioned, included an impressive cohort of 2,690 patients. What does a sample size of this magnitude allow you to conclude that smaller previous retrospective studies couldn't?
Yeah, well, obviously the larger the denominator, the more reliable your findings are. Your point estimates become a little more reliable. Your 95% confidence intervals get tighter. So that always just provides more reliable information. Of course, in retrospective studies, we don't do power analyses, as you all know, so you can't really speak to power. But again, the larger the series, especially when you're doing point estimate type stuff, the more reliable that point estimate becomes. Also, it allows you to do more sort of subgroup analyses because then you have potentially more patients in each subgroup, especially when folks are trying to publish on BMI cutoffs and obesity cutoffs. They all use different cutoffs, and often they just use one cutoff because it's just easier and they have more cases that way if they just dichotomize the data. Because we have such a large series, we could actually break it down and look at the BMI groupings slightly different, which Sarah will touch on in a little bit. So there's a lot of value to a large series like this in terms of what you can do statistically. Again, it's still all retrospective, of course, but being retrospective, I mean, these are our results that we see from the surgeries we're doing. So, and these included all the patients we had during that time that were stage one, surgical stage ones, and had SLN mapping attempted.
Right. So, Sarah, I'll turn to you for this question from Ana Conde in Madrid, Spain. And she's asking, the median BMI in this study was 30.9, but the range went all the way up to 70.2. So when breaking them down using the CDC category, there were no differences between groups. How did you categorize these patients to make the BMI data clinically meaningful? And perhaps if you can talk a little bit about what is the CDC category for our listeners.
Sure, yeah. Like Dr. Lateo started to mention, we really wanted to hone in on the impact of BMI on our SLN mapping success. And so we examined the data categorically and continuously. prior studies had cut off BMI at different categories, and the CDC uses BMI for other medical uses, and it just isn't quite as helpful from a surgical perspective when considering SLN mapping. So for the CDC, BMI less than 25 is normal, 25 to 29.9 is overweight, 30 to 39.9 is obese, and greater than 40 BMI is severely obese. And we found that more practically for us, it made more sense to consider BMI along a scale. And so we grouped the BMIs as less than 30. So normal BMI 30 to 39, BMIs 40 to 49, and 50 to 59. And then BMIs over 60. And we found that SLN success decreased slightly as the BMI increased, but the SLN success, even in the patients with a BMI of 50 to 59, remained relatively high at 83%, but then decreased significantly to 69% with BMIs over 60. So in our non-obese patients, BMI less than 30, we had an excellent SLN success rate of 89%. And when you use the CDC categories, it doesn't quite break down into anything meaningful from a SLN mapping success perspective.
Right. And also, most of us who have been doing this for 20 years and such, you realize that, most papers use the CDC criteria and say obese is over 30 and then do their analysis. But I don't find that to be really truly surgically obese, to be honest with you. I think most of you understand what I'm saying. And I never really felt I was having trouble doing SLN mapping in that group of patients, even the over 40s. Once you start hitting 50 and above, they were a little worried. And then when we looked at our data on a continuous variable, which is the best way to analyze continuous data, is you analyze it as a continuous, variable. There was a significant difference of 0.03 on univariate, and actually on multivariate was less than 0.01. But then if you just use CDC categories, there wasn't a significant, and that just reflects that's maybe the wrong categorization, and that might be the wrong categorization for any future study. That really, I'm like, well, if the increasing BMI is associated with it, but then the categories aren't telling us, then where is the break point? And that's why we also broke it down the way we did. So I redefined categories, and that's the problem with sometimes categorizing things, that you have the group over 40, which the majority are less than BMI of 60, but the difference was really at that group of over 60. So that was why that was also helpful to do it that way, because, from a clinical standpoint, we can now reliably say that BMI less than 60 were very, very successful. Even over 60, a bilateral mapping rate of 69% is not too bad, if you ask me. But so that's why we did it that way, and it coincides with the sort of the continuous variable analysis of BMI and not dichotomizing it up front. And that also highlights for many people doing these studies that you are always better to analyze your variable if it's continuous in a continuous fashion, and to not and always do everything in some kind of cutoff point, because you actually might miss important information that way. Because a lot of times those cutoff points and those categorizations are somewhat arbitrary. So just things to keep in mind as folks do their studies.
Yeah, and it gives us an insight into those kind of extreme obesity cases as well. Mary, I'll say with you, this next question comes from Alice Sampolini at the Policlinico Gemelli in Rome, and she's asking about the surgical approach. The vast majority of cases, 93%, were completed via minimally invasive surgery. How many cases required conversion to laparotomy, and why is that transition an important variable to track?
Well, yeah, there's a lot of reasons to track that. I mean, obviously, cases that you start MIS, and then switch to laparotomy, those are probably some of the more expensive kind of cases to do. So there's a lot of reasons for that. Also, those are probably longer cases because you start with MIS, and there's a lot of reasons to convert to laparotomy, as we all know. So I always find that a valuable way to look at your surgical data. And then we were also curious to see, did this impact our successful SLN mapping? And I can tell you sort of personally why I thought that might impact it in a second. The overall rate of converting laparotomy was pretty low. It was 1% overall. But again, sort of background data. We did look at the robot versus laparoscopic non-robot approach, and it was a little bit higher with the non-robotic approach, and I think there is some benefits to the robot that might account for that. But here we really emphasize the need to do MIS with whatever tools you use, whether it's a robot or otherwise. So we don't want to make a big highlighted point on that. And again, and that's why it's important to track these things, because that is a different approach, in my opinion. You start MIS and you open, that's different from starting MIS, staying MIS, and then opening and staying open. I think that is a different surgical category to really analyze when you're looking at surgical outcomes.
Excellent. Sarah, as you know, obviously ICG is not available everywhere. This next question comes from Christina Kohler. She's in Heidelberg University in Germany. And she's asking, you report an overall success bilateral SLN mapping rate of 87%. How does this stack up against older historical data using technetium-99 or blue dyes?
In short, I'd say much improved over technetium and blue dyes. And I think important in examining the prior data is that many publications either report SLN success as a single SLN noted during the case, so not bilateral SLNs, or it was a study where the patients had dual methodologies of detecting ICG or of detecting the SLN, so technetium and a dye. Technetium-99, generally the reported success rates are anywhere from 48 to 65%. Tesla 1 reported bilateral SLN mapping for technetium-99 as 57% versus 78% for ICG. Blue dyes such as isosulfan blue and methylene blue, generally their success rate can be reported as 40 to 50%. There was a systematic review by Badertha Smith who reported bilateral mapping success at 51% for blue dye versus 75% for ICG. And a prior publication from our institution by Erickson et al. Found that ICG mapping rates were superior to blue dye at 85% versus 53% in all comers. And they noted that this difference widened in obese patients.
Excellent. Camila David from Houston Methodist, and she's now with us in our research team. She's asking, while mapping success remained high for most groups, it dropped to 69% for patients with a BMI of 60 or higher. What unique intraoperative or anatomical challenges explain this drop at this extreme end?
Yeah, so in this study, we considered mapping as failed if there was either no mapping or unilateral mapping or an empty nodal packet. And we found that the empty nodal packets did not statistically significantly increase or worsen, I should say, with increasing BMI. Unilateral mapping was the most common reason for failure, and that occurred in 57% of the failed cases. And the second most common reason for failing was due to an empty nodal packet, and that was a quarter of the failed cases. So, with increasing adiposity in the retroperitoneum with our patients who are increasingly obese, the evaluation of the retroperitoneum and those nodal basins can be more difficult. And if a patient has significant retroperitoneal adiposity and also a low-grade carcinoma, the surgeon may be more likely to more quickly abandon SLN mapping and just treat based on uterine factors.
Excellent. Mario, question from Ezra Belir in Germany. Bilateral mapping was significantly lower in laparotomy cases, 75% compared to almost 90% in MIS. Why do you think an open approach seems to hinder the success of mapping?
Well, I think a few reasons, and I can't prove this objectively. This is obviously just personal sort of impressions. One, open SLN mapping is much more difficult and painful to do. Okay, that's just the reality of it. Every time I have to do open SLN for some other disease, which we won't mention here, I'm always quite unhappy. Because you don't have this continuous view of the surgical field as you find in sentinel like you do with MIS. MIS, you're overlaying things. With open, yeah, I get the detector out, put it over the area, It's very hard to hold the detector and sort of do the map, the dissection at the same time, right? And then what you do is you put the scanner over it, whatever detector you're using. Then you kind of say, there's a lymph node. You kind of grab it with the pickups, and then you hope you don't let it go. And then, so I think, and then also it's just harder to see in a deep pelvis and a narrow pelvis. So there's so many reasons why I think laparotomy. I mean, 75%. It's what other studies report for all their case. So it's still not bad, but there's definitely reasons I think that makes sense why laparotomy has a lower. And there are other studies that actually have noticed this also, looking at SLN mapping, that open and MIS tends to have a better SLN result. I'll just leave it at that. Also, the cases that convert to laparotomy, and the other reason too is that since we do very few laparotomy cases, most of those cases are also being done for very large uteri, right? They're also being done. These are all stage 1 cases, so no, they're not, but they're not grossly metastatic cases. We wouldn't do SLN mapping, so that doesn't apply. But we do it for a large uterus, fibroids, and you can't even see the side walls at the time. And then by the time you have to take the uterus out, and by the time you take the uterus out, it's just a general mess in the pelvis. Um, so I think there's a lot of reasons for that. And then if you convert to open, you know, you're ready. It's a longer case, and you convert to open because something's not going right. And then you figure, like, what's the point of doing the SLM mapping at that point? You just want to finish the case almost. So I think there's a lot of reasonable and rational and plausible reasons for why laparotomy would result in a slightly lower mapping rate.
Sure. Sarah, let's talk a little bit about age. Chiara Ainio from Mayo Clinic, she was asking, on a multivariate analysis, increasing age was independently associated with a decreased rate of successful mapping. What biological or anatomical differences occur as patients age that might cause this?
As patients age, the lymph node parenchyma is gradually exchanged with adipose tissue. This is called lymph node lipomatosis. It's very common, but we don't speak about it all that much. And so just as a patient gets older, their lymph nodes become less nodal and more fatty. So that could contribute to lower success rates. Additionally, as a patient ages, they're more likely to have more tortuous vessels, which can be more difficult to dissect and may preclude a safe SLN dissection. And in an older patient, a surgeon may be more likely to abandon the difficult SLN dissection and just additionally treat based on uterine factors if it's going to be very difficult.
Yeah, I think that's actually, now talking about this, we may actually want to look at breaking down these age categories too, to see
Hmm.
where there might be a cutoff. Because obviously our age, went up to 96 years old. So our age. So, you have a 96-year-old and she's got a grade 2 tumor, and it's tortuous vessels, and you're like, all right, enough of this. I'm not going to you always have to balance risk and benefit, right?
Yeah.
And as we know, there's many folks just looking at uterine feature treatments, which we don't agree with because I think there's a lot of value to nodal information. But in some cases, you say, well, I'll use the uterine features for this case because it's just the risk benefit ratio is kind of diminishing here.
So perfect segue to my next question. Obviously, as you know, Mario, we went from open surgery with full pelvic and periodic lymphadenectomy, so then to minimally invasive surgery with similar staging, and then we moved down to just a sentinel lymph node algorithm. So then now the next question, and as you alluded to, given the context of the study and the principle of de-escalation, what are your thoughts pertaining to the potential concept of doing no lymph node assessment at all? As you know, there's an ongoing randomized control trial titled the Endo-3 trial out of Australia, comparing hysterectomy alone versus hysterectomy and sentinel lymph node mapping. Would it not ideally make sense to go by intrauterine findings alone, particularly in these very obese patients? Should we wait till the results of the Endo-3? What are your thoughts?
Yeah, and as a disclosure, I am a reviewer of surgeon videos for qualification for participation in the trial, just so you know. We are not participating in it though, otherwise. Um, yeah, that's a concept. Anytime we can't find the sentinel node, we'll fall back to this why just don't do anything at all kind of thing. And then we use that as sort of a uterine only sort of excuse. But we do feel that there's great value in knowing what the nodal status is. You know, if you really look at all the prognostic stuff we're talking about, including all this push from molecular, if you look at what the most prognostic information is, it's stage. So first you get best prognosis. We're all trying to push for expensive molecular studies and IHCs, when actually it's not as good as stage if you compare it head to head. Two, I think now with emerging treatments, it really will impact. And I think a study like Endo-3, that might get a little watered out in a large group of patients, and the outcomes get average, and you actually lose a little bit of your precision. As well, push for precision medicine. I think we need to get as much information as we can, as long as it's not too risky for the patient, of course. Because honestly, if you have an endometrioid carcinoma currently, and they're node negative, there's no trial that's ever shown a benefit to additional therapy. No matter what, pull out any trial you want. Don't tell me Portec 1 and 2, because those were unstaged cases. So that doesn't even apply. So if you look at every single study that's been randomized, looking at whatever risk category you want, looking at chemo and radiation, none have ever shown a PFS or overall survival advantage. So I think it's very important there. Whereas if they have node positive disease, endometrioid, you can impact outcome by giving chemo, at least based on GOG 258, right? So, and then if they're DMMR, you can even argue for giving IO, where if you just use uterine features, you'll never be able to give immunotherapy if it's available to you, right? So, and now for a while there, we were sort of saying for carcinosarcomas, serous carcinomas, dedifferentiated. Well, we give them all chemo anyhow. What's the point, right? Um, I actually don't disagree with that concept. But now, those cases, if they're stage 3, they could potentially get immunotherapy, right? So you can potentially alter their outcome. So I think that actually in an era where we want more precision care, everyone talks about precision medicine, I think not doing nodes is less precise. And it's not a hard thing to do. And cost-wise, it's much cheaper than doing polymutational status and all the IHCs that we do. If you really look at the cost of IHCs, they're not cheap. So I think there's great value in knowing the nodal status of patients. Again, it's an individualized risk-benefit decision. If it's a difficult situation, like we just talked about in the older patient and obese patient, I don't push to do something that might be unsafe, because we've all been there with a deep pelvis, a thick retroperitoneum, you can't see the vessels. The last thing you need to do is cut through the optic nerve because you're trying to get out some fat lymph node, or get a big venous injury in the internal iliac system, and you have bleeding. I think that's the benefit is no longer there, in my opinion. And then we can fall back to plan B, which is treat by uterine features.
Excellent. So just a few more questions, and I'll turn to Sarah. What do you see as the weaknesses of this study?
So those certainly inherent to any retrospective study. Additionally, the patient demographics of this study may differ from a different surgeon's institution. We may have a population with a slightly different BMI or age. Additionally, there were few patients that had BMI greater than or equal to 60. It's only 0.6% of the entire study population. So it can be a little difficult to, or our conclusions should be made with caution at that high BMI. But overall, I think that patients with obesity were very well represented in this study, with over 50% of our patients being obese.
Excellent. And actually, Mario, I'll ask one more question to you, because I know a lot of members of the audience will want to know what do you do in the OR when you remove what you consider maybe the sentinel lymph node or that packet of sentinel lymph nodes. You're not so sure. It looks like fatty tissue. Do you do anything in the OR yourself? Do you send it to pathology?
Yeah.
What should they do?
Yeah, I can only speak for myself. I know that my partners here probably have slightly different approaches. Again, I think usually if you're uncertain, what I do is I actually go fill the packet myself, and you can bisect the packet. I mean, you can really tell if there's a lymph node it looks different. Again, there's a little bit of experience with that. I don't, frozen sections are not free. And I think that actually ruins the sentinel node. That's why we don't do frozen sections on our SLNs in most situations. So I never send for frozen. I think most of the time it's quite obvious, at least with me. I've been doing it for a while. I think it's quite obvious. And again, I have occasionally just gone to the side, gotten the lymph node, put on a pair of sterile gloves, felt it myself, dissected it, sort of cut it in half, and then I can see if it is or isn't. And often when you have a node in there, you can, if it's just fat and you kind of roll it enough, all that fat's gonna melt away,
Mm,
right? And
mm,
then the lymph node won't. You can't disintegrate your lymph node with fingers. So, I think if you do enough of this stuff, you should be able to be confident in feeling whether there's a lymph node in there or not. I think use of frozen section to detect nodal tissue is kind of a waste. Of money, and it's a waste of pathology time, especially at a big center, busy center where there's a lot of frozens being done all the time. It takes 40 minutes sometimes to get a frozen just because of the volume of frozen sections that's done at our center. So that's my approach. I think if you ask some of my other partners, they may have a different approach to it. I do think some of them do send it for a frozen, to be honest with you, but I'm not certain. I think it's a very personal decision.
Okay. So, Sarah, as a last question in tradition in the podcast, we put your study through AI. And the question that was set by AI is the following. Previous large studies used a BMI cutoff of 45 to show a drop in success. Your study refined these groups further and found that high success rates, up to 85%, are actually maintained deep into severe obesity, with a sharp decline to 69% only when a BMI of 60. What do you suggest to our readers to achieve these high success rates?
Use the SLN algorithm published by Barlin et al. Carefully and meticulously evaluate every nodal basin with attention to identifying the key anatomic sites. Expose the most common locations for the SLN node, including medial to the external iliac vessels, ventral to the internal iliac, and in the obturator region, and map everyone regardless of their BMI.
Yeah, I think that it's really when you get to the BMIs over 60 where that retroperitoneal adiposity becomes a real issue. Um, Again, a lot of this is just doing a lot of this, just like anything else. The more you do, the more comfortable you get at doing certain things. And SLN, like anything else, surgical is a technique, it's a skill. And the more you do, the better you get at it. So I think understanding the anatomy, also understanding where the most likely locations are for the sentinel node is also important. It's almost always, I'd say 60%. We've published this about 60%. It's the obturator space is where the SLN is. And then you have external iliac next, internal iliac, much less common. Much less common is the common iliac area. And then occasionally you'll see these subaortics that follow that lower pathway that some people have talked about. So I think understanding also where the more likely spots are will help get you to that spot in a difficult case and not just follow around through the entire sidewall. So if I have trouble, I see a faint channel, I'll start dissecting the obturator space. I leave the externals to come. I don't fuddle around there looking for a sentinel node because it's less likely to be there. And then if you get bleeding, and once you get bleeding in the spaces, you're really going to have trouble finding a sentinel node, especially if you use any color-based stuff. So you have to really keep it dry as possible and such like that. So again, even like I said, even amongst our group, there's variation among the 15 surgeons that were included in this study that are made up the database for the study. So there is some experience that's built into there and volume of surgery that you're doing.
Excellent. Well, I want to thank you both. Excellent podcast. I really appreciate the opportunity to discuss the manuscript with you, and certainly we always learn a great deal from speaking with you, Mario, and then Sarah. Again, fantastic job in your, I believe, first podcast with us at IJGC.
Yep.
So again, I also look forward to the Journal Club as this is the July lead article. So once again, thank you for sending the manuscript to our journal. Thanks for your time accepting our invitation.
Oh, thank you so much. And congrats on the impact factor of 5.4. I got to say that.
Thank you.
Sarah.
Thank you so much.